So I suppose, how many people have actually, people have said that they've seen it, they know something about it. How many people have actually downloaded the software and used it or shown them? So a few people. Because I guess that for us, what the HEF is, it's not just a tool or an instrument. It kind of begins as a way of sort of thinking about how people with learning disability. So when we were developing this, and we were thinking, what are the outcomes that we should look to measure, we recognised that people with learning disabilities are in lots of different settings, nurses are working in lots of different ways, lots of different settings, and what's the kind of commonality that would cut across the outcomes that probably in all service areas that we're achieving. And I guess that we recognise that this underpinning sort of concept of health inequalities and people being exposed to things that drive the differences and these discrepancies and outcomes is pretty much common wherever people with learning disabilities are, wherever nurses. And then as we went on with the development, we recognised broader applicability to other disciplines. We recognised that that was the kind of commonality that went everywhere. So in developing the HEF, I guess what we also looked to do was first and foremost have something that was valuable to the health of people with learning disabilities. And let's have something that would inform nurses and other practitioners and family carers in supporting people in relation to the health of it. Having done that, of course, the other thing which it then does is it sort of kicks out this data. So we can use it. I presented it recently, and I remember there was a group of professionals talking about how do we get the national data aggregation and how do we interpret and interrogate it. And there was a chap there who managed a small sport accommodation service, and he commented that you guys can talk about that as much as you want, but actually he said, I'm minded to take this back to my service this afternoon, profile some people's health needs and change their health action plans tomorrow. So it's that kind of dual sort of role that sort of cuts through the whole sort of initiative. So on the one hand, it's about informing the way that we understand people's propensity to poor health outcomes and how we can reformulate our care and address those things in different ways, whilst at the same time it's kicking out data that we recognise that if we can kind of get into models of handling aggregated data, we can understand not just the health of individuals but also the health of populations. So as a result of that, it's not a symptom-based thing. It's not about, here are people that are ill, we're going to measure how many symptoms they've got, how severe they are, and then monitor the reduction. So it's quite a sort of proactive way of thinking about things. And it really is absolutely fundamentally sort of built on the quality of the evidence base that came to us from IHAL. We have good evidence that these are the things that will drive and will give rise to and will create health inequalities. So on that basis, these are the legitimate targets for our interventions, rather than waiting until people get ill and then measuring how clever and how innovative we are in reducing their symptoms. So it sort of shifts the way that we think about things. So it's not intended to replace other outcomes tools. People no doubt have experience of RSLD and ECOS and Recovery Star, Lifestyle. We measure people's pressure areas. We have all manner of other outcomes that we monitor and that we measure. So the HEF kind of doesn't replace any of those things. It's an overarching thing that's proactive, that's about preventing health inequalities, not letting people get to the stage where they're in hospital and experiencing unequal outcomes. So that's a very practical way. So that all those other outcome measures still need to be there, and if they're relevant to practice and relevant to a person's particular clinical presentation, then very much continue using them. So it's about sort of measuring sort of lifestyle changes, and that if we can work across the 5 determinants of health inequality, that over time we can make significant and lasting lifestyle changes which will be associated with better health outcomes. So I guess what HEF does, Phil mentioned that fundamentally it's about measuring and trying to understand and analyse the nature of a person's exposure to those things that determine health inequality. But it's also about recognising the interventions, whether that's at a practitioner level, whether that's at a service level, whether that's at a broader, on a societal level. But what are the interventions that we do to reduce the impact of it? So it's reducing exposure, but where we can only reduce exposure to determinants to a certain point, then how do we, through our interventions, reduce the impact of that exposure? So that's kind of what the HEF will measure for us. So it kind of gets very much sort of wrapped up in sort of quality of life, because we know that people are more actively engaged in their communities, they're taking part in sort of in broader society, they're enjoying healthy lifestyles as the easiest option, as the default option, that the quality of life improves. So it's quite a sort of rounded tool. It's not based on a sort of medical concept. It's not based on notions of illness. It is very much a sort of social, inclusive model in terms of understanding health. I've probably already talked about these. I tend to jump around and do so many things. So yeah, so you know, it's about measuring the impact of practice. What is it that we do? So we can profile an individual. We can say, you know, at point A, this is the degree of exposure to these determinants, and this is the impact that it's having on the person that it's likely to have. And then point B, we have a period of intervention, of lifestyle change, of engagement with family carers, that's with professionals. We remeasure. We compare before and after, and essentially, that's our outcome measure. So it starts to sort of inform our practice. One of the things that we know, when we did the pilot work, there were kind of two sort of components to that. Initially, we did a one-off census across the 4 areas geographically that we worked in at the time. So we got a batch of community nurses with various titles, but essentially community nurses. And on one day, we went out and we asked them to randomly select a number of people off their caseloads and to profile those individuals. And there's feedback on how the tool's working, how the indicators were framed, etc. And what people were telling us really, you know, it's 12 months ago, at quite an early stage, people were telling us that as a result of going through that process, they were changing the priorities within people's health action plans, they were reprioritising within their caseloads, and it was starting to shift the way that people were thinking. So people, particularly for me, some of the nurses I worked with at the time, will say that actually all of our health action plans are focused on symptoms when people are ill and conditions, but actually maybe we should have a whole batch of stuff in health action plans about how we minimise people's exposure to the determinants of ill health, and of health inequalities. How do we have some of that kind of proactive stuff in there? So it's starting to make people think differently about health. So yeah, so it starts to sort of change practice. Of course, with that kind of data aggregation model, because we can gather and aggregate data for caseloads, for geographical patches, for one team versus another team, starts to give us some means by which to sort of measure and to make direct comparisons and to kind of strategically start thinking about where we go with services. So the determinants of health inequality, well, that's a long way up there. There are 5, so we know that, I'm not going to read through all of these, I would suggest that we do, so we know that we've got a range of social determinants. These are things that we would, I guess, all understand from our own lives and from people around us, not alone from the people that we work with. So, you know, we know clearly things like accommodation, how socially isolated you are, your employment status, whether you've got good stuff to do through the day. Clearly these things impact on our health. We know that people with learning disabilities, assuming that we all work with people with learning disabilities, are more likely to have adverse exposures to those sorts of determinants. So we have 5 determinants. We have social, genetic, biological, we have kind of communication and health literacy issues, we have behaviours, sort of personal health behaviours, do people smoke, do people drink, do people have unhealthy sexual behaviours, and then we have a whole range of issues around service quality. So the way that the HEF is put together, we have the 5 determinants. Underneath each of the determinants we have a series of indicators. You'll notice that for most of the determinants there are 6 indicators, and for one of them, communication, there are in fact only 5. And that's basically because that was what was in the evidence base, the evidence that we got from IHEAL. So we weren't into kind of just chucking and making stuff up to have a nice symmetrical tool. We worked with what the evidence told us. Sometimes people come to us and being waved at, I'm going to have to speak up. And sometimes people come up and ask us about what things. Someone came and said, you know, why did we not have an indication in there about spirituality? Now, I have no idea whether spirituality has any bearing in terms of the person experiencing health inequalities. Maybe it may not do, but that wasn't in the evidence base that came to us, so it's not in them. Okay? So the whole thing sort of rests on the validity and on the rigour of the work that IHEAL had done that underpins this. So for each of those indicators, we're then have essentially a risk scale. We're all familiar with these things. Sort of, you know, green is where we want to be. Green is you're going to have minimal health inequalities. We can minimise the impacts of any exposure you have to determinants of health inequality. Red is clearly a very bad situation. So we created a range of kind of overarching scales, which you'll see in the paper copy of the HEF that you've got in front of you. So for 29 indicators, we've had to go through and kind of construct the wording. So we've got a high-level statement and then a descriptor to help people make the appropriate rating. Essentially, when you start profiling people, we would say start at red, read down as soon as you get some aspect of the person's situation or presentation that's consistent with that, that's the correct rating. If you're having a dilemma with yourself, is it red or is it amber, is it a 4 or is it a 3? Then go for a 4, because if you're having that dilemma, kind of rate with the multi-thought system. This is, come to my workshop this afternoon, and this will be with all sorts of incredible graphics whiz around the screen. I've been tempted to go into sort of practice my presentation, but we will outline how to use it, how to pick it up, how to easily put data into it, how to get that data out, how to make sense of those profiles. I really don't know. Input scores. For those of you, you've got the screenshots of this in the manual in front of you. Simple way of inputting data. It takes, our nurses that have been using this tell us that once you're used to this tool, it takes about 20 minutes, 25 minutes to profile somebody. So to put the data in, to generate it, and then to view pretty much instantaneously, visually and graphically, the profile. So there's a couple of components. Obviously we register individuals, and we also include some basic graphical details and that kind of crude profile areas of need. That's important when we move on to handling aggregated data, because we can understand people's exposure to determinants of health inequality and kind of relate that and kind of cut that data in terms of the clinical issues that people face. This is the actual rating scale, so it works on Microsoft Excel. This is the data input page, and essentially it's a case of going, I'm going to walk in front of that again. It's essentially, we go through, we click the radio buttons, red to green, you've got the descriptors and the manual in front of you. So this is the bit that takes about 20 minutes to fill in. You'll notice on your right-hand side that when you click on one of the radio buttons, you get a prompt that comes up in this screen that's kind of above my head. The notion there was that in terms of having a tool that's quick and easy to use, that you don't have to kind of manual around. Maybe you might use that the first few times as you get used to the tool, but once you've got to grips with it, you carry it around on your laptop, it's the office on the computer, and you've got all the verbal prompts there.